Welcome back to Between Two White Coats, a podcast designed to help you be the healthiest version of yourself. I'm Dr. Michelle Plaster, a family medicine doctor.
And I'm her co-host, Amber Foster, a family nurse practitioner. In our combined 30 years in medicine, we've seen a lot.
We're discussing key issues surrounding health and wellness, answering some of our biggest questions, overcoming health obstacles, and giving patient-centered advice in hopes of educating you and providing the tools you need to live a healthy life.
If you find our podcast helpful, please consider subscribing so you don't miss an episode. And don't forget to leave us a 5-star rating and review. This will help other people find our podcast.
Thanks for joining us. We look forward to serving you. Welcome back to Between Two White Coats, and thank you for joining us today. Today feels kind of funny in our topic because we are talking about overprescribing.
And we're prescribers.
And we are talking about the harms of prescription medicines, and we give them to people all day long. So please excuse us for being hypocrites, but we actually, as medical providers, recognize the harm that prescriptions do. And I was saying to Amber before we started recording that there are two kinds of medicines that this is a quote from a book I recently read that I would recommend called The Magic Pill. It's about semaglutide. But the quote from a pill manufacturer in there is there are two kinds of medicines: those that work, and they have side effects, and those that don't work.
Yeah.
And so if you're taking a medicine and it's doing something, it could also be doing something that doesn't make you feel good. That is, like every blood pressure pill listed has a side effect of hypotension. That's low blood pressure. So what does that mean? It means we can bring your blood pressure down with this pill, and then we can bring it down too far. So sometimes the side effect is actually the effect.
Yeah.
It's just too much of it. And so what we want to talk about today really is, do you need to be on all those pills? Should you be on all those pills? Please, please, please do not listen to this and say, I'm not going to take any of my prescriptions anymore. That is not the takeaway message. But we do hope that this will elicit some good conversations between you and your medical providers to talk about, do I still need to be on all this medicine? And can we have a real conversation about all the medicine and whether it's doing more harm than good or more good than harm?
Yeah.
And so polypharmacy is our fancy phrase for this. Polypharmacy is when you are on more than 5 prescriptions, and I have patients who are on lots more than 5 prescriptions.
Pages.
And I will go through, as passionate as I am about deprescribing, trying to take people off of medicines, and I really don't want you to be on anything that you don't need. I got people on 15 pills and we decide they need them all.
Yeah.
But how do you get to that place of knowing that the medicines that you're taking are medicines that you need? What would you recommend patients do to empower themselves here?
Oh my goodness, there's so much. Okay, so initially I would say that when I am prescribing something, so from a different perspective, not the patient, but from my perspective, I am glancing and seeing, okay, what are you already on? What, like if somebody's kidney function is off, for instance, like this is not something that you guys even would know to do, but like looking at your kidney function, and if it's went down, then I'm looking at the medications that could potentially cause the decrease in the kidney function, and like, do you really need that medication, or is there an alternative? So as a prescriber, that is what's going on in my mind.
Yes, and many times when we choose, like there's a lot of blood pressure pills, there's a lot of diabetes treatment options. And so many times when we choose, we're looking at the whole picture of, well, this medicine can affect your kidneys in a bad way, and you don't have perfect kidneys to begin with, so I'm not going to choose that one.
Yeah.
But know that some of your specialists, so we're primary care, we're going to look at all
Big
of
picture.
the systems. But some of your specialists are very much, this is what you need for heart
they haven't
failure.
seen-
I'm your cardiologist. I don't even know. We don't even talk
your
about
kidney
your psych
function.
meds. So
Yeah.
I'm not worried about how some of these blood pressure pills may induce depression. And then we sit with them and go, oh my gosh, it took us years to get your depression right. Maybe that's not the right blood pressure pill. So, I do think the conversation with the primary care is an important one. And you want to, when you get put on a new medicine by your specialist, start it. You don't have to have our permission to start it. Start taking it, do as your specialist says, but make sure that you bring that to your next visit.
So that's what I was
going
to say is initially from a patient perspective, when you're prescribed something, I want you to question me. I want you to say, okay, is this the best option? Are there other options? Are there non-pharmacy options? Like I tell people every day, your blood pressure's horrible. You know what I'm going to do? I'm going to give you a blood pressure pill. And then what else I'm going to do is make you keep a log of it. And I'm going to make you watch your diet and exercise, because you know what? You probably could come off of this medication if you lose 20 pounds.
Right.
But nobody wants to hear that initially. Some people are a little fearful of medication. I will say that. But for the most part, people would rather say, oh, we'll just do this and it fixes the problem. Well, you could fix the problem without the pill.
Right. And as your prescribers, we don't know if you're going to fix the problem without the pill or not. What we know is that your blood pressure is dangerously high, and if we leave it dangerously high, you can have a stroke. So we need to get your blood pressure down in the short order.
Yeah.
But make the lifestyle changes and keep having the discussion to say, can I come off some of these medicines? And sometimes people will lose 20 pounds. And our fragmented healthcare system, so you have a primary care who's not interested in doing weight loss with you, so then you're getting weight loss online from a person that you don't think your primary care is going to approve, so you don't really even tell them that you're doing this. And so it's disconnected, and then you've lost 30 pounds, and you're still on all this blood pressure medicine, and you're still on all this diabetes medicine.
And you're dizzy, and you're passing out.
Yeah, and your blood pressure is in the toilet low, and your sugar's running too low, and you don't need all that because you've made the good lifestyle change and you've reversed obesity. And so you can ask, can I come off of some of these medicines? And I think that's recognizing that everything that gets started, and I have so many patients who are like, I don't want to start a blood pressure medicine because I don't want to take it the rest of my life. And I'm like, well, if this isn't like horribly genetic, you probably don't have to take it the rest of your life.
So I would say at least like question, and then be willing to do the other hard things. And that's not for everything. That's me kind of saying like metabolic type stuff. But
so everyone who takes medicine that works is going to have a side effect of some sort. It is a real possibility.
Yeah.
It's not everyone. Some people take pills, they don't feel anything. But there's when it's doing something in your body, there's a real chance it could do something negative. Yeah. But that doesn't happen with eating right and exercising. No. That's not like, and here's all the list of negative things that could happen.
You might have more energy. You might lose a little bit of weight. Like those are negative.
Right. And so please be compelled to make the better choice. And when you make the better choice, then you can use fewer pills.
Even like with reflux, like people could eating earlier in the evening. Like there's things you can do that you don't necessarily, you may need a medication.
And please know, I'm so glad you said reflux. This wasn't even something I intended to point out, but if you take stuff over the counter, don't think that means it can't do you any harm. There's no big deal. Taking too much ibuprofen can fry your kidneys and cause heart problems. Taking too much reflux medicine, everybody wants to use the over-the-counter proton pump inhibitors. Taking too much of that can cause a lot of issues downstream, years into the future. So don't forget to tell your provider what over-the-counters you're using, but also don't think that just because it went over-the-counter doesn't mean that it doesn't count as part of the 5 medicines that you're taking being too many. Yes.
It just lost the patent.
Like many people might not know that. Lots of times things go over-the-counter because the patent's up on it and there's no money to be made by keeping it as a prescription. Many times things are prescriptions because there are safety regulations and they want a provider to prescribe it. But sometimes it has to do with they just lost the patent.
Yeah. Uh-huh. So I would say initially, bring your medication.
Every single pill that you swallow, your supplements, your over-the-counters, the thing that the cardiologist gave you.
Yeah.
Please know that when you bring the pill bottles, because many times people will have a list and you do not change your list every time someone changes your medicine.
Or they'll say it's blue and it's a little square or it's a little circle. And I'm like, I have absolutely no doubt. I don't take
Even if we had seen pills, and we have not. We are not pharmacists. Yeah. At no point do we ever see these pills. The only time I would see a pill is if I actually take that pill myself. And even if we had seen it, there are a million manufacturers. Once something goes generic, it can look like anything. Yeah. Like, your pink triangle pill will be a white circle pill next week. Yeah. Because they got it from a different manufacturer. So do not think that you can tell your provider that it's the blue triangle and they'll know what you mean. Yeah. Bring your pill bottles and and that often, many, many times we realize when you bring your pill bottles to the visit that you have on your list, you have atenolol. That's what you always took. It's your old beta blocker blood pressure pill. You've been on it forever. Then you went to the hospital and they don't have atenolol on formulary. So they switched you to metoprolol. And then they discharged you with the one that you were taking there. And they wrote you a prescription for it. And you filled it, and you now have a atenolol bottle that you're swallowing and metoprolol. And it's really, one should have been in place of the other. It's dangerous to double dose on these things. But if you bring both those bottles in, particularly after you've been in the hospital or you've seen a specialist or you've had any kind of med change, we'll catch that. Yeah. And we'll be like, no, don't take this one. You're supposed to be taking this one. So if you are taking a pill, if you're swallowing that pill, please bring all those bottles to your visit, and then that makes us aware of what you're taking.
Yeah, and then also don't assume that we are getting all those records. So sometimes they'll be like, you didn't get that record, and I'm like, I had absolutely no idea because I haven't gotten the records yet. And so sometimes we won't even know that something's been changed because they haven't sent us the stuff yet.
Right.
And so med reconciliation is a big deal, which is kind of the fancy term for bring your medication, let us know what you're taking. Bring your medication,
let's update the chart, let's review it, make sure you're taking what you're supposed to, what we think you're taking.
Yeah.
And if anything's been added, we're aware of it. And then when you start pushing over 5 pills, take control of that. Empower yourself. You don't have to just be okay with the fact that you're on 13 pills. I hope you're not okay with the fact that you're on 13 pills.
And know what they're for. Often patients don't know what they're for. And sometimes that's on us. Like, that's poor education. But make sure, take the initiative.
You can ask your pharmacist. Yes. When you go to the pharmacy, this is one of the things I dislike, that mail order pharmacies become so popular and kind of mandated by insurance, because we've removed a very important part of the healthcare team, the pharmacist. Yeah. You can ask your pharmacist to write on the bottle what it's, that this one's for blood pressure. Now, some medicines are for multiple things. They can be given for multiple reasons. And so the pharmacist might not know what our motivation is. But when you bring your pill bottles in here, I'll grab a Sharpie and I'll write exactly
I got a black Sharpie in my rooms. I love a black Sharpie.
Yes. And we will write exactly why we have you on that medicine. So yes, know what it's for. And then there are things where if you empower yourself and you make lifestyle changes, or if you say, can I come off one of these blood pressure pills? I am always happy to try. So deprescribing is something that I love to do. And I have a very powerful story that was powerful to me on one of my patients I've been taking care for a really long time. And he recently moved in with his daughter, and his daughter's been very active in his care. And she said, can he come off some of these medicines? And he's on way too many medicines. And I prescribed most of them. And I say he's on way too many medicines because in the past, I couldn't really get him on board. He was like, well, the pills make me better and I need the pills. And he didn't want to stop taking any of the pills. And I couldn't get his buy-in. And so now that she's involved, she's like, can we start coming off these? So we had a full way that we were going to deprescribe. And I was like, well, let's start with this one because this is the one I think he needs the least. And I want you to cut it to half. And then if you notice these symptoms, then he needs it. So we'll go back up. And if at half he doesn't notice it's gone, then go ahead and remove it in a week. And if he still doesn't notice it's gone. So, some were things he'd been on for a long time. His things have changed. He didn't really need it anymore. Mm-hmm. We ended up getting him off of 5 different prescriptions, which had him down, I think he was on 11. And had him down to like 6 prescriptions. And she said he now gets up and walks to the store and hangs out with buddies during the day, every day. He has a social aspect. He's getting exercise. But before, he was taking his medicines wrong, and he was on meds that were making him tired, and he was tired all day. Yeah. So he didn't do anything. And now that he's doing more, we'll probably be able to get him off of even more medicines. Yeah. But there were multiple visits to that deprescribing. So I said, let's try this one for a couple weeks, and then here's what you're going to be looking for. And then if that goes well, then I want you to go with this one. Then I want to see you back in a month.
Yeah. And there has to be buy-in. You said there's buy-in.
There has to be a buy-in.
Because it's hard to come off stuff, especially if you're a little apprehensive, if you're worried about something going awry, like, oh no, my blood pressure might go through the roof and I don't want that to happen.
And if you have buy-in and you recognize the importance of trying to deprescribe, then you can monitor at home. So if there's buy-in and you're watching, am I going to start pulling you off of blood pressure medicines and diabetic medicines? No, not if you're not monitoring. Mm-mm. But if you want to call once a week and say, here's what my sugars are this week, then I'll be able to say, yep, good. Let's come off of another one.
Yeah.
But I need to know what your sugars are to make that decision.
Yeah.
So you're
and
absolutely right. There
sometimes
has to be buy-in.
Like some medications, like thyroid medication. I'm never going to tell a patient to come off of thyroid medication because the adverse effects of not being on thyroid medication, if you have hypothyroidism, it's not worth, like, I'll be like, no, we're not coming off of that one. Let's go on whichever other one.
Particularly, like, you're on 100 micrograms. It starts at 25. I'm going to be like, well, you have a normal thyroid level on 100. I doubt that this is something you come off of. I'm not going to take you off of it. But I have taken people off of thyroid medicine because they were on like 25 micrograms.
Oh, no,
baby dose. And they were like, I've been on this for a long time. It got started when I was just a few weeks postpartum. And pregnancy can jack up your thyroid levels. And 25 is so little that it probably never made them too high. So I'll say, here's all the symptoms of low thyroid. If you start having these symptoms, then you need this medicine.
Yeah.
Let's come off of it and let's test your level again in 6 weeks. But if you start feeling bad of any of these things, then you're going to go right back on it.
Yeah.
And so even on the stuff that's kind of weird to come off of, there are times you can at least initiate the conversation. And we might outright be like, you're on 200 micrograms.
You're never coming off.
That is a lot and you need it. Or maybe you were started on this in a time and things are different, and antidepressants, not something I want to rock the boat. I'm not trying to throw people into depression. But when you tell me I had 3 losses in a period of 6 months, I couldn't get out of bed, it was horrible, and I was in a terrible, stressful job, I made lots of changes, I've come through my grief, and I'm wondering if I can come off of my antidepressant, then I say, well, we're going to go slow. We're going to really pay attention to how we're feeling.
And there's screenings for that too, so that we can screen to see kind of if that changes.
How is your sleep? How is your appetite? We're going to ask all the questions, and we're going to have you prepped for that. And then we start pulling back slowly. So if you were on 100 milligrams of Zoloft, then I go, well, maybe we step down to 75, or maybe we step down to 50, and we do that for 2 or 3 weeks, and we get steady there. And if you feel horrible, we go back up to 100. Yeah. We don't just yank it away and then, have all the consequences of it. But in working with someone, working with your medical team, then there's a lot of things that may have been situational. So anyway, you're smart and you're like, don't do that. And I'm like, no, I do it all the time. But there are even times where people go, oh, someone told me I'll need this forever. And it's worth a conversation. So bring your medicines, know what your medicines are for, go through the medicines. What else is our advice to our patients?
Take the medicine that you actually do need consistently.
Yes. And so all of this conversation of saying more is not always better in medicines, but more is sometimes better.
Well, and sometimes you just need to take them.
Sometimes you need them. I will go through, I love the conversation, but sometimes the end of the conversation about can I come off of any of these medicines is no.
And sometimes I'll do it by like, well, this medication is for your blood pressure. This medication is for, so sometimes it is just education. Like this is for your cholesterol. This is for your vitamin D deficiency. Yeah. Like maybe you can come off of some of this, but maybe you can't.
And it's person specific. Yeah. So I may have a person who is like, do I still need to take this cholesterol medicine? And I look at their cholesterol levels. I'm like, man, your cholesterol levels are great. You have never had a heart attack or a stroke. You aren't super high risk. You're not a smoker. You don't have all these other things throwing you overboard. Let's not take the cholesterol medicine for
6 months.
6 months, and let's retest you. Or let's not take it for whatever period of time, depending on how aggressive you want to be. And let's retest you. And if you tripled in your cholesterol, guess what? The only thing keeping it down was the pill. Yeah. But if your cholesterol is okay without it, but then there's other people where they say, do I need to be on this cholesterol medicine? I'm like, you're 95. The odds of you getting
having a heart attack,
really high cholesterol over many years are not very good. The research doesn't support that heart attack prevention is happening in 95-year-olds. So the whole reason that you were started on this in your 60s isn't even there anymore. Come off of it. Come off of it. Yes, you can come off of it. And then there are people who it's like, I don't care how old you are, and you have had a heart attack, you have had a stroke, you need to be on a cholesterol pill the rest of your life, and I'm never going to be the one to stop it. Yeah. Because bad things might happen if we stop it. So if you think, well, my friend stopped taking this, so I can. It is so person specific and situational that it's got to be a conversation with a trusted medical provider.
Yeah. And I do think it's a conversation, and you may want, if that's something you're interested in, you may want to do a visit just specifically for that.
Yes. And I would say on behalf of all white coats, when you come in and we are managing your diabetes, your high blood pressure, you now have this infected leg with a terrible rash, and you have all these things. I'm not even going to get to look at your med list that day. Like, let's be realistic. I've got a certain period of time to manage all those things, and I'm just going to refill what you're on and address the other issues. And so if you feel like, and I want to talk about all these medicines I'm on, make an appointment just for that. Let's focus in on your med list. Let's focus in on, why are you taking this? Do you really need it? That is a great reason. And if you start, or if you have a parent and you're taking care of someone and you're like, wow, you're on so many pills, make an appointment to come in and just discuss, what are all these for? Could we start trying to not have all of these pills? What would I be looking for if we tried to stop some of them? That's a great conversation to have, but it is frequently a visit by itself, and a valuable visit, not a waste of anybody's time.
I was going to say our e-clinical system, which is who we use, who's our electronic medical records. A lot of times you can print the med list. And so sometimes for patients who have polypharmacy, who are older, we haven't mentioned Beer's list yet, but medications that may increase risk for falls, I will either highlight those, or I will say, hey, we made this change to this today. You need to throw this pill away if they didn't bring them. And so sometimes I will just print the med list and say, hey, watch for this, or X this one out.
Yeah.
So they actually go home with that as well.
Yeah. And if you bring your bottles, I'll put a big X on the bottle. And so you don't go home and go, which one was I supposed to stop?
Yeah.
And you brought up a really important point, that polypharmacy becomes a much bigger deal in our older patients. As we age, we don't clear medicines as much. Medicines store in fat more than muscle. As we age, there's more fat, less muscle. Our metabolism isn't as great, so we're not metabolizing, so the drugs hang around for longer, and a lower milligram can be a higher milligram in older people. Also, kidneys might not be as great, and we're not clearing it as well. So medicines that were safe at 50 aren't always safe at 80. There's an entire list of medicines called the Beer's list. It's named after, and it is spelled like beer, like drinking beer, but it's named after Dr. Beers, who made a list of different drug classes and different drugs to say, here's what happens when we give this to the elderly, and here are the potential side effects. It doesn't mean that those prescriptions can't be given. It means that we need to analyze the risk and the benefit. And increased risk of falls, increased risk of sleepiness and sedation, and memory loss and confusion. Many times people come in and they'll say, oh, I don't know what happened with mama, but I think she has Alzheimer's. She can't remember a thing. She's real confused. And it was a new medicine.
Yeah. And
so if you start noticing things like that around the start of a new medicine, it is likely that someone is older and that medicine is not agreeing with them. And so there are a lot more risks with our older patients. But unfortunately, it is these older patients that they got a medicine started, and then they got another medicine started, and over the years, lots of medicines have been started. I say all the time, doctors are great at starting pills. They're not great at stopping them. Yeah. So having the conversation about what stopping them might look like, and whether at this point in time in your current situation, you still need all these medicines, especially if it's an elderly person, is such a valuable conversation. There are many, many hospitalizations every year because of polypharmacy, because of people who have drug-drug interactions. There are many bounce backs to the hospital after discharge because of having the wrong medicines or using them wrong. We are passionate about being on the pills that you need, but we are also equally passionate about not being on the pills that you don't need. So we would like to empower people to really start that conversation and say, do I really need to be on all these medicines? I think you may find that your prescriber is a lot like we are, and we welcome that conversation. So think a little bit about polypharmacy and whether you really need to be on all those meds. We'd like to leave you on a good note. So here's today's Tell Me Something Good, brought to you by Tracy, who is one of our Wellness Center co-coordinators.
Hello. My something good today is I am thankful for my family and my 7 wonderful grandchildren and a place that I get to work every day and with some amazing people.
Oh, thank you, Tracy. And according to my parents, you should skip the kids, go straight to the grandkids.
Absolutely.
Grandkids are definitely something good.
Absolutely.
Yes. Send them home when you've had enough.
That's right.
Thank you so much for joining us today. And until next time, take care of yourself.